Hi class, in this video we are starting with a discussion of OCD, obsessive compulsive disorder. And it generally involves intrusive and unpleasant thoughts as well as repetitive behaviors. So let's break this down. OCD is when you experience thoughts and urges that are intrusive and unwanted, and or the need to engage in repetitive behaviors or mental acts. Those thoughts are the obsessions. They're characterized as persistent, unintentional, and unwanted thoughts and urges that are highly intrusive, unpleasant, and distressing. The way you deal with those obsessions is with compulsions. Compulsions are repetitive and ritualistic acts that are typically carried out primarily as means to minimize the distress that obsessions trigger, or to reduce the likelihood of a feared event. Common examples of obsessions are things like germs and contamination, doubts, orders and symmetry, so you keep thinking, is everything in its right place? Urges about aggression or lust, safety, those sorts of things. And examples of common compulsions are going to be things like repeated excessive hand washing, cleaning, checking. So you have to check your stove 5 times before you leave the house to make sure it's off. Because again, these tend to be ritualistic. It's not just practical, let me check it once. There is a ritual involved. Counting, ordering, praying, reciting something to yourself over and over, all these things can be compulsions. When you do a compulsion, it's not done out of pleasure. You don't enjoy it. And it's not connected in a realistic way to the source of the distress or the feared event. For example, if you're worried about your house burning down, checking your stove exactly 5 times, and then coming back and checking it 3 more times every day is not going to make it less likely your house burns down than if you just check it once. But you have to do the compulsion in a specific way. For OCD, the lifetime prevalence is 2.3%. It is not very common. And it tends to be chronic. It is very difficult to just permanently get rid of it. It tends to be something you have to continually work at. And so what I'm going to do now is show you a video of a woman who has OCD and sort of the treatment she went through. She went through a cognitive behavioral treatment to deal with her OCD. But her OCD involves germs and contamination for her obsessive thoughts, as well as safety connected with her son. And so her obsessions involve checking and excessive cleaning and hand washing. So watch this video now.
Her obsessions center around her baby son, Jake.
When I come to stop signs, I have to look at him while I'm stationary for fear that someone's going to come up and take him, open the door. I have to start the car before I take my eyes off him. When I'm moving, I figure nobody can get to him.
Stephanie's protective maternal instincts have gone into overdrive. It's a form of OCD that sometimes afflicts new mothers.
Like it, don't like it, don't like it. Just doesn't like. Okay.
Okay. To set this trap, I'm going to use a video cassette, which I shall lean against the door. Then I'm going to take this pen and line it up along the green rectangle. And I'm going to point this napkin so the edge, if you follow it with your eye, matches up with the corner of my wall.
Stephanie fears that someone might kidnap Jake, even when she's at home with the doors locked and the alarm on.
I'm not sure if somebody might have gotten in the house while I wasn't here, so I'll set a trap. I will set things up at a certain angle that if they're moved, I'll know it. It's so pathetic.
for a walk?
Stephanie knows her thoughts are irrational, but they're beyond her control. Protecting Jake from every conceivable danger makes life hard.
Okay, get your stick. When I can't take my eyes off Jake, it's literal. I stare at him. If I glance away, even like this, it's a chance for something to happen. He has to be in front of me so that I can see him the entire time, so that if somebody walks by, I know that they aren't going to bump him, spit on him, grab him, touch him, inject him with something, whatever. Take him.
Like many people with obsessive-compulsive disorder, Stephanie also has a fear of contamination. She avoids litter or spots on the pavement in case the wheels of the buggy touch something deadly. Passers-by pose a double threat. They could kidnap Jake or contaminate him.
Just need to make sure nobody was near him. Cigarette? If I looked away, I'll have to turn my stroller around, look behind me to see if anybody was in the area, but then I worry that maybe I took my eyes off him while I was checking to see if anybody was behind us. So I'll turn back around, and then I'll turn back around the other way, and I'll just spin around in circles until I feel relatively sure that it's okay. Sometimes it's hard for me to go for a walk because I can never get home, because I'm constantly having to turn around and go the other way because there's somebody coming. If somebody's walking towards me, then I get frantic.
No, that's... please keep him on a leash.
And it's a fear of never knowing if he was contaminated. It's like I'll never know if that person who walked by touched him. And that will eat away at me.
Before Jake was born, Stephanie was diagnosed as having OCD. Her obsessional fear of contamination leads to compulsive rituals which she uses to manage her anxiety.
When I am going to interact with Jake in some way, I have to be certain my hands have been just cleaned. And they have to be scoured clean.
The urge to perform these compulsions is so strong that in this half hour, Stephanie washed her hands 22 times.
It's torturous. I wash my hands continuously. I know I try to stop myself, but it's almost like my feet begin moving for the sink, and I'm trying to tell myself not to do it, but I'm desperate and I have to.
And the washing ritual is complex and has to be performed absolutely correctly 3 times.
I have to lather up my hands completely, drawing my fingers through my other hand. The water has to be as hot as it can be. I start with my forefinger and scrape under my left thumb, and then I switch to my thumbnail and go to my forefinger, the middle finger, ring finger, and then I get to the pinky and I switch to this hand and go back and forth several times, and that just gets the first layer of contamination off, because I still feel, since I scraped under my nails, that it's somewhere on me. So I have to get another pump and do it all over again. And this is really the one that I feel cleans me, because now my nails are clean, and now I'm just going to scrub my hands. And then I have to do a finishing rinse. This is the part that's hard because the water's really hot, burning, but sometimes I keep my hands under there just to feel better. And then I get my towel, and I will be careful not to touch the garbage when I put this in, so I have to, and it touched my hand, so I'm back. But it dries your hands out and your hands crack, and then it gets to the point where I can't close them more than this because the knuckles will crack open and bleed.
It's always been there. It's been noticeable, but it's been manageable. We could joke about it. We could kid her about it. We could do things, to set her off. but it wasn't an issue until Jake was born, our son Jake. Since then, it's been uncontrollable.
Ready? What do you want to do with that?
Stephanie is desperate to start treatment as she realises the real danger to her son comes from her obsessions.
I'm extremely worried about the effect this is having on Jake. I'm so desperate to take good care of him. And the OCD has a negative effect on him. On his dresser is the soap pump. He puts his hand at it and rubs his hands together. He was doing that at 1 year old. And that struck me that I need to do something, because no 1-year-old should be, pretending to wash it. That was the first thing he pretended to do was wash his hands.
So that is an example of OCD. What causes OCD? There are several things that go into this. One, it's partly genetic. So you are 5 times more likely to get OCD if you have a first-degree relative with OCD. So, for example, if one of your parents has it. So partly genes. It's partly neurological. So your, what is called the orbitofrontal cortex, which is in your frontal lobe, it's connected to decision-making and learning. That part and a couple other parts sort of create an OCD circuit that is more active when your symptoms are provoked. So your brain plays a little bit into it. Those are both going to be biological perspective factors. And there's also a behavioral cognitive component where you basically learn the emotional value of the stimulus and how it's connected to the behavior and the thought you do. So you kind of learn your way into OCD as well. But again, it's not in a way that is actually functional or helpful in your everyday life. So that is OCD. The next thing we will go over is body dysmorphic disorder and hoarding disorder. By the way, your book also talks about PTSD. I briefly mentioned that in the stress chapter, and so I'm not going over it here, but if you are interested in learning more about PTSD, which is an anxiety disorder as well, you can take a look in your book and learn more about it. But the final two we're going to talk about are body dysmorphic disorder and hoarding disorder. Body dysmorphic disorder is when you're preoccupied with a perceived flaw in physical appearance that is either non-existent or barely noticeable to other people. So this usually involves things like your hair, your skin, that sort of thing. The lifetime prevalence for this is 2.4%. And for body dysmorphic disorder, your prefrontal cortex is associated with this as well. For hoarding disorder, this is when you can't bear to part with personal possessions, regardless of how valueless or useless they are. So you are going to accumulate excessive amounts of useless, worthless things. It clutters your living place. It can make it uninhabitable. Hoarding, to be diagnosed with hoarding disorder, it can't be caused by another condition. Like you're too sick to throw out things. It's got to be separate. And the part of your brain that's connected with hoarding disorder is the anterior cingulate cortex. So that is also a stress disorder or an anxiety disorder. And that is it for anxiety disorders. The next type of disorder we're going to talk about are mood disorders. Mood disorders are characterized by a severe disturbance in your mood or your emotions. Remember, moods, the difference between moods and emotions, moods are not caused by a stimulus, an outside thing. Emotions are. Moods tend to be less intense, but longer lasting. Emotions caused by a specific thing, more intense, shorter lived. There are two main categories for mood disorders: depressive disorders, and what they call in the DSM-5-TR, bipolar and related disorders. Depressive disorders have depression as the main feature. So we will go into these a little bit more on the next slide, but generally speaking, depressive disorders involve depression. Bipolar and related disorders, the main feature is mania. And mania is a state of extreme elation and agitation. You know, you're excessively talkative, reckless. Again, we will get into bipolar disorders after we talk about depressive disorders. So the first mood disorder we're going to talk about is major depressive disorder. Major depressive disorder, the main symptoms for this disorder are you have a depressed mood most of the day, nearly every day, and you have a loss of interest in your usual activities. In order to be diagnosed with major depressive disorder, you have to have 5 symptoms for at least 2 weeks. And these have to cause significant distress, impair your normal functioning. They can't be caused by a medical condition or a substance. And you have to have at least one main symptom. Those main symptoms being depressed mood most of the day, that loss of interest, and 4 symptoms from this list: significant weight loss or weight gain, so you have an increase or a decrease in your appetite, difficulty falling asleep, or you sleep too much. You have either psychomotor agitation, which means you're like really fidgety, or you're pacing around, or psychomotor retardation. You don't move as much, you're monotone. Fatigue or energy loss, feelings of worthlessness and guilt, difficulty concentrating, you're indecisive, suicidal ideation, so you have thoughts about death, you're planning a suicide or making an actual attempt. So again, one of the 2 main symptoms, and then 4 of the other symptoms in order to be diagnosed. And major depressive disorder is usually considered episodic, which means that the symptoms are strong for a while, but then decrease. However, if you have one major episode, there is a good chance you're going to have another episode of major depressive disorder. So for example, 50 to 60% of people who have one episode are going to have a second one. If you have 2 episodes, 70% of those people are going to have a third. If you've had 3 major depressive episodes, 90% of those people are going to have a 4th. So it does increase in the chance that you have it. But only 12% of people show signs of impairment after 5 years. So it tends to be episodic, but it doesn't tend to be chronic long-term. Only 12% of people show signs 5 years later. So what are some risk factors for a major depressive disorder? Actually, before we get to there, the lifetime prevalence, the chance you will be diagnosed with it in your lifetime, is 16.9%. It's a little higher for women, 20%, a little lower for men, 13%, but 16.9 overall. The yearly prevalence is 6.6%, and it's higher in North America and Europe. It's lower in Asia. It's higher among people in the lower age cohorts. So that might be because they're more likely to have symptoms. It might be because younger people are more willing to talk about having depression, and so they're more likely to be diagnosed with it. Some risk factors: unemployment. You're more likely to get it if you're unemployed. If you earn less than $20,000 a year, if you live in urban areas, and if you are separated, divorced, or widowed. There are subtypes of depression. The DSM-5-TR calls them specifiers. So they're not specific disorders. You're diagnosed with major depressive disorder, but they're labels that are used to indicate specific patterns of your symptoms or to specify certain periods of time where those symptoms are present. So for example, if you have the seasonal pattern, this might be called like the winter blues. So you experience symptoms only during a certain time of the year. Peripartum onset, this is going to be postpartum depression. So women who have major depression during pregnancy or within a month of giving birth. You can have persistent depressive disorder. This used to be called dysthymia. Now it's called persistent depressive disorder. If you have this, you have less symptoms. So you have 2 symptoms of major depressive disorder rather than the 5. And you have a depressed mood most of the day, nearly every day for at least 2 years. So it's longer term than just the general major depressive disorder, but it's less severe. So that is persistent depressive disorder. And that's it for depressive disorders. For bipolar disorder, this is when you have mood states that switch between depression and mania. To be diagnosed, you have to experience a manic episode at least once in your life. So mania is the main symptom. You don't have to have major depressive disorder to be diagnosed with bipolar. It's just the one manic episode. For a manic episode, this is a distinct period of abnormally and persistently elevated, expansive, or irritable mood, and abnormally and persistently increased activity or energy lasting at least 1 week, and it lasts for most of the time each day. So you can feel euphoric, you can be irritable or hostile, you can have what they call flight of ideas. So a flight of ideas, you switch between topics really quickly. You're easily distracted. You might have grandiosity, so you have an unjustified self-esteem or an inflated self-esteem. You can go days without sleeping during a manic episode. You can be reckless and engage in dangerous activities for fun. Yes, so there can be some negative consequences. If you have the rapid cycling subtype, what this means is you've had at least 4 manic episodes within 1 year. So that is a subtype of bipolar. For risk factors, I am going to talk about risk factors for mood disorders as well as bipolar together in this video. One thing specifically for bipolar, the lifetime prevalence rate is 1%. So for risk factors, again, we'll look at it from the biological and diathesis stress model, as well as some neurological factors. For the biological factors, it is partly genetic. There's a strong genetic basis for both mood disorders as well as bipolar, more so for bipolar. So if you have a close family member with it, you're twice as likely to have a mood disorder and 9 times more likely to have bipolar disorder. So significant genetic basis for that. For example, if you are going to look at twins, and when one person has a mood disorder or bipolar, what are the chances the other twin will have it? For mood disorders, or major depressive disorder specifically, if your identical twin has it, you have a 50% chance of having a major depressive disorder as well. For bipolar, it's 67% chance you will have it if your identical twin has it already. Another factor neurologically is neurotransmitters. Norepinephrine and serotonin are two neurotransmitters that play a part in these disorders. For major depressive disorder, you have too little activity for norepinephrine and serotonin. For bipolar, you have too much norepinephrine activity. So, for example, one of the treatments for bipolar is lithium, and what lithium does is it blocks norepinephrine receptors in the synapse. When another neurological factor with major depressive disorder is the amygdala. You have too much activity in your amygdala. You also have elevated cortisol levels for major depressive disorder, stress. If you're going to look at the diathesis stress model and major depressive disorder, stressful life events can trigger depression. So that's the stress component. You have what they call exit events. Exit events are episodes where an important person leaves your life. It can be through something like death, or it can be something like a breakup or a divorce. But exit events, someone exits your life. These often happen before a major depressive episode. So that's that stressful life event trigger. It's especially likely to trigger depression if it happens in a way that humiliates you or devalues you as a person. Another sort of stressful thing that can lead to depression is traumatic stress from childhood, like maltreatment, or if your parents get divorced, you are more likely to get depression at some point if you've experienced that. So again, that's the stress component of the diathesis stress model. Oh, my dog wants in. Both of them. For the diathesis part, the predisposition, you have, for major depressive disorder, you have a change in a specific gene, the 5-HTT-LPR gene. And this regulates serotonin, because remember, serotonin plays a part in major depressive episodes. So a shorter version of this gene is a predisposition for depression. So if you look here, the chance you get a major depressive episode or chronic depression in adulthood, if you have the long version, it doesn't matter if you were maltreated as a child or not. Low chance of depression as an adult. If you have the long version of the gene and you have no maltreatment, you're still not really likely to get it. If you have no genetic predisposition, you have that long version, but you had maltreatment in childhood, about 50% get it. If you have the genetic predisposition, but you don't have the maltreatment, it's about 20%. If you have both the genetic predisposition and that stress component, the maltreatment, 70% chance you will develop depression as an adult. That is that diathesis stress model. The highest risk is when you have that combination of the predisposition as well as the stress. You also have a cognitive basis for mood disorders. Beck says that depression is triggered by negative thoughts and interpretations. So your expectations can be off, all that fun stuff. The diathesis stress model would say it's triggered by cognitive vulnerability. So you have negative thinking, maladaptive thinking, and stressful life events. Aaron Beck says that depression-prone people have depressive schemas. So depressive schemas are mental predispositions to think about most things in a negative way. So you tend to think more about loss, failure, rejection, worthlessness, all that fun stuff. And these depressive schemas can develop early in childhood in response to negative experiences, but they stay dormant until a stressful or negative life event reactivates them in adulthood. Then these negative schemas come back out, and they prompt dysfunctional or pessimistic thoughts about you and about the world. And so these depressive schemas are maintained through cognitive biases. Cognitive biases are errors in how you process information. So you might focus more on the negative aspects of an experience. You're going to interpret things negatively. It's harder to remember positive memories. Those can all be the negative biases. So that's what Beck says. You have the hopelessness theory for a cognitive perspective for mood disorders, which says that it's a particular style of negative thinking that leads to a sense of hopelessness. And that leads to the depression. And there's nothing you can do to stop it. So hopelessness, you assume that hopelessness is an expectation that unpleasant outcomes are going to occur. That what you want to happen isn't going to happen. You can't do anything to stop it. It's just going to be that way. Bad things are going to happen. A key assumption with this is that hopelessness stems from a tendency to perceive negative life events as being stable and global. So they're always going to keep going, and it's going to affect all different aspects of your life. This theory predicts that people who have this cognitive style, this hopelessness, in response to bad life events, will view events as having negative implications on their future. This bad thing happened now, it's always going to happen. And so that is going to increase the likelihood of hopelessness. That is going to increase depression. So people who have this negative thinking, more likely to be depressed because of the hopelessness. The final cognitive theory and the final thing with mood disorders to talk about is rumination theory. A rumination is a repetitive and passive focus on the fact that one is depressed and dwelling on negative symptoms rather than distracting yourself from the symptoms or attempting to address them in an active, problem-solving manner. So this theory focuses on how people's thoughts about their depressed moods can increase the risk and duration of the depression. So for example, women are more likely than men to ruminate when they have a sad or depressed experience, and the tendency to ruminate is associated with an increase in depressive symptoms, increased risk of major depressive disorder. So if you ruminate on your depressed state, you are more likely to stay depressed. So those are all perspectives on the mood disorders. And I'm going to stop that video here because that's the end of mood disorders. We'll start schizophrenia in the next one.